Okay, hello everybody, and a very warm welcome on behalf of IPC Partners and the Healthcare Infection Society and the Infection Prevention Society to our next Insight webinar. Today, Phil and I are really delighted to have Alex Sundermann join us. We're going to be talking about genomic surveillance for IPC, principles and practicalities. So Alex has been a bit of a forerunner in this field, doing some really powerful research that I know he'll touch on as we go through the webinar. So, hello, Alex.
Hi, John. Nice to see you. Thanks, Phil, and good morning from the west coast of the US.
Fantastic. I know you're covering at least 2 time zones at the moment, so I hope you cope all right with that.
Oh yeah, got my coffee and I'm ready to go. So that's all I need.
Fantastic. Hello, Phil.
Hey John, great to be here. I'm sat outside in sunny Brighton. So me and Alex were just chatting before we went live. I'm down at a launch event with the medical school here down in Brighton, and it's a glorious day. So first time I can say I've sat outside this year in 2026.
Fantastic. All right. Well, look, before we get going with the webinar itself, I wanted to ask you a question, Alex, and your views, welcome, Phil, on how do you think this space has changed, genomic surveillance and IPC, in the last 5 years? How is this conversation different today than it would have been in 2021? Actually, that's a bad question because that's right in the middle of COVID. So ignore COVID.
Well, yeah, definitely. Yeah, it's changed a lot during COVID, but I mean, pre-COVID, I think the biggest thing has really been cost has come down. That has made mainly the research more affordable to actually look into the utility of it. I mean, years ago, I mean, it used to be hundreds and hundreds of dollars to sequence a single infection. And now, as I'll cover in my talk, I'll talk about our own laboratory's costs of what it looks like. It's very affordable, and it has allowed, I think, the research to occur over the few years, especially during COVID-19, where we're doing a lot of genomics. And I think the next step is kind of what we're going into is, okay, we've done the research. Now, how do we make it an actual tool? And I think those are kind of the next hurdles as we go forward here. But it's definitely going to be the cost that's really changed.
Yeah, I don't want to be too boring and agree with Alex. I think that um, that's where I'm really interested, is how we kind of implement it into practice now. I guess if I was answering that question, I feel like a lot more people are talking about it. I feel like there's a lot more awareness now, and we've kind of got some really good peer-reviewed evidence, particularly work that Alex has done. I know that James, as well, in the UK, James Price, has also done a lot of work in this area. So I think there's more awareness of it. But I guess the next 5 years, I'm really interested to see about how it fits into healthcare and practice.
Yeah, I was going to touch on the evidence actually. If we think about what evidence we had for even retrospective, reactive whole genome sequencing, it wasn't brilliant 5 years ago, and there wasn't really anything for proactive whole genome sequencing. So I think the evidence base has come a long way, and we now even have some cost effectiveness evidence to talk about. Okay, well, look, before I hand over to Alex, let me just run you through a bit of background about these Insight webinars. The idea is that we give you some expert insight into a particular relevant topic. Today is genomics, but we've got plenty of other topics lined up over the course of the year. We're keen to generate discussion. It's quite a big audience today, so we're expecting quite a lot of questions. So I'd ask you to put your questions early into the Q&A, which will maximize the chances they'll get asked. There's also an uplift option on the Q&A, so you can kind of click on a question to like it, and that puts it up the top of the queue. So please use that today. And then we can be really audience-led in our questioning of Alex at the end. If you've got a general comment or you want to share some experience, feel free to pop that in the chat. We want to provide opportunities for CPD, both formal and informal. This event is accredited for a CPD point from the Royal College of Pathologists. We want to think critically. Through our work with the Journal Club, we want everybody to come at these studies, Alex's studies, everybody's studies, with questions like, well, what's not there as much as what is there? So to think critically about these issues. And in doing so, try and build confidence for your own independent research and study. I think we already have, and we're keen to nurture this network of enthusiasts and to the extent possible, have a little bit of fun. So without further ado, I will stop sharing my slides and hand over to Alex.
Wonderful. Thank you, John. So let me pull up my screen here. We did this right before. I'm a Zoom person, but let me get my, here we go. I think you see my whole screen there. Do I look okay here? And I'll switch to the presenter mode. Wonderful.
That's perfect.
Perfect.
All right.
Thank you, Alex.
Sounds good. Yeah, so thank you, John, and thank you, Phil, again for this opportunity to kind of talk about our research, about the field in general, too. You know, I've shared some of our research in the past at an IPS conference, but we've come since then, and there have also been plenty of other individuals in the world that have kind of researched this. Here are my disclosures. I won't be talking about any commercial specific for genomics, but I will mention a commercial, commercial solutions in broadly. But what I'll talk about today is kind of where genomics is for IPC right now, the basis of what genomic surveillance is, the ins and outs, and then the third topic is more of a, how do we get this at our hospital? Because right now there's not really many people doing this in their actual applied practice. So what are the questions? What are the needs? What's the pitch that you have to make? And then kind of the barriers to actual implementation that our field in general need to work together to actually overcome. So first off, starting with genomics for IPC, as John alluded to, he mentioned retrospective versus prospective type of genomics. The phrases that you'll hear me use throughout this talk and in the papers that we publish is reactive versus surveillance. So what infection prevention field does currently is the top in the red. And I will actually say not everybody in infection prevention has the capability to do this, where you have a bunch of infections that naturally, unfortunately, occur throughout the hospital. And then it takes multiple infections to actually cause an alarm of a suspicion of an outbreak. It's always the clinician at 5 p.m. on a Friday that gives you a call that says, hey, we have, a few MRSA patients with infections that we think that we might actually have an outbreak. So what the infection prevention department has to do is gather a line list, do an investigation, talk to the clinicians, do audits, etc. And as I mentioned, only some facilities have the capability to sequence those isolates reactively, retrospectively, determine relatedness. And what we have found and what others have found, and I'll show the evidence in a minute, is that it's usually not an outbreak. The thing that we thought was an outbreak usually says none of these are genetically related, or very few of them are genetically related, meaning that they're not transmitted. They could still be hospital-acquired infections, but there's not an outbreak. So the interventions have to be different. On the other hand, on the bottom, what we're interested in and other people are interested in, and this is where we think the field is going, is prospectively sequencing infections as they occur in the hospital, which allows you hypothetically to detect the outbreak that would have been 20 patients. You can now detect it at 2 patients and then make the interventions of where the transmission occurred, whether it's equipment, shared equipment, and then actually stop the infections from ever have occurring in the first place. And the issue with this, as Phil alluded to, the research is coming up, but it's hard to prove the counterfactual scenario, this counterfactual scenario, which shows us the cost savings and the evidence. And that's what we'll kind of go through today. But where does the current state of infection prevention happen right now? So what do we do now? Does it actually work in infection prevention? This was a paper that was just out, actually, I think this month, from the group at University of California, San Francisco, where they evaluated their genomics program over the course of 7 years. They had 2 types. They called it rapid response genomics, which is the reactive sequencing, and they had a few pilot genomic surveillance programs. I don't have it on here, but there are pilot genomic surveillance programs where they sequence a bunch of things, found many outbreaks, many useful things that they would have otherwise not known. But interestingly, from their paper, they point out that their rapid genomics ruled out many outbreaks. So that 33 out of 48 suspected outbreaks were actually not outbreaks whenever they did their genomics, meaning that all of those resources would have been allocated to that outbreak response, which would have been wasted because none of them were outbreaks themselves. This also from UK in Addenbrooke's Hospital from Sharon Peacock's group did genomic surveillance for MRSA over 12 months. And just MRSA, they showed that the sequencing of MRSA isolates provided de-escalation for what infection prevention thought were outbreaks, but whenever they sequenced them, turned out were not outbreaks. So there's this great utility of showing that you don't need to invest all of these outbreak resources into what you think are outbreaks. They can still be HAIs, but it allows you to allocate it somewhere else. And then this is our research, which I'll talk about a bit more in just a second. But what we showed is that over 2 years of doing genomics, what infection prevention thought were 15 outbreaks, comprised of 130 patients. Only 5 of those patients were actually true outbreaks, meaning that we misidentified all of these outbreaks of what we thought were outbreaks. So it shows us what we're doing right now in infection prevention is actually pretty inaccurate whenever it comes to determining what are outbreaks. And now let me tell you about why what we do also misses many, many outbreaks. And I'll be talking about broadly our analysis of our program here at UPMC, University of Pittsburgh Medical Center, University of Pittsburgh, where we wanted to show the utility, the value that genomic surveillance brings to infection prevention. And we intentionally divvied it up into 2 different steps, 2 different phases. The first being a retrospective analysis. We wanted to see, as I alluded to before, what does the normal current status of infection prevention find over the course of a 2-year period versus if we were sequencing a lot of our infections, what would genomic surveillance find in that exact same 2 years? We did not inform infection prevention of any of our findings except for 1 outbreak because we intentionally wanted to compare the 2. So for 2 years straight, November of 2016 to November of 2018, we sequenced patients' infections of major pathogens if they were essentially in the hospital for more than 2 days or had some prior healthcare exposure in the prior 30 days. And we sequenced it, determined if it was in an outbreak, determined the transmission routes, and again, did not inform our infection prevention team except for 1 outbreak. So over the course of 2 years, we sequenced 2,700 patient infections. And you can see on the figure on the left, which is hanging above in my office because I just like the rainbow type colors. Each dot represents a sequenced infection, and on the inside represents those infections that are clustered into outbreaks. So you can actually glean a lot of value in terms of implementation whenever you look at this figure, because you can see for Pseudomonas aeruginosa, you actually have to sequence a lot of Pseudomonas aeruginosa in order to find a few clusters, but those clusters were very impactful. The one larger pink cluster in the middle was a cluster of 6 patients that had a shared endoscope over the course of a few months. And after the fact, in our routine infection prevention practice, that same endoscope tested positive for Pseudomonas aeruginosa. When they did the look back, they looked back 1 month prior. None of those patients were on there, but all of these patients were in the prior 6 months, meaning it was the kind of smoking gun that put it all together that our current practices missed, but genomic surveillance actually picked up. But then you look at vancomycin-resistant ephysium, which is the dark blue sliver on the top. We sequenced a good bit, and the majority are actually genetically related. This large dark one right here was an outbreak that we also published separately, where over the course of 6 months, we had 10 patients all housed on different units in our entire hospital. So not one single unit common, which kind of goes against what we traditionally see. And the only thing in common among all of them is that they received interventional radiology procedures. So whenever we actually went up there and looked at it, we found that they were essentially injecting unsterile contrast into our patients, which was compliant with the manufacturer's recommendations of the practice that they were doing. So we actually had to fix that practice, report it to the manufacturer, and changed it, and we haven't seen anything else. So all in all, we had 99 outbreaks comprised of about 300 patients that went completely undetected in this 2 years. The infection prevention department didn't get any of those outbreaks, whereas they missed all these outbreaks and they thought they had 15 outbreaks, which were not outbreaks. What you see on the right was our cost savings analysis, which showed if we hypothetically had intervened in real time, what could we have saved? Conservatively, we could have saved many infections if we have intervened, and we could have saved upwards of $700,000 in net costs by not treating these infections. So we had great data that hypothetically this could work in a real-time aspect. So that's why we shifted to this phase 2. So starting in November of 2021, we started real-time weekly genomic surveillance, and then every single week we would review these outbreaks and inform our IP team. So what does this look like in practice? This was a preprint by our lab supervisor, Katie Waggle, that it's under review right now. You can find it on medRxiv as a preprint, where we describe our entire process, our collection process, our laboratory process, our sequencing, our bioinformatics, are all in detail, which is all publicly available. Even our bioinformatics analyses, our tools, we publicly uploaded onto GitHub. We don't, it's none of this is proprietary. We publish it all. So how it works every single week is that we make a list of what isolates we want to sequence that week. We go down to our clinical lab, we collect them, or for C. diff, we have to grow them out in an anaerobic chamber. We process the samples, do DNA extraction, library preparation, and we actually send them out to an industry company for the sequencing because they're able to sequence it for a bit cheaper, which I'll get to in a minute. And then we use our pipeline, again, using publicly available tools to determine where the outbreaks are. And then I do an initial review of each outbreak each week of likely what's causing those outbreaks. And I send simply a line list to our infection prevention team. I don't send them a phylogenetic tree. I don't send them any genetic data. It is simply a line list with an idea of where the transmission is going. And then they make interventions based upon that. And I mentioned cost, and we are very open about our costs. This is part of that preprint analysis that we put online. We wanted to see how much is it costing us to sequence for the laboratory materials, but also FTEs, personnel costs that are dedicated to doing this. And the bottom right-hand corner, you can see that we've optimized it, that we can now essentially get our average cost per sequencing between $45 to about $60 per isolate. We can actually even get that lower. And that's because the throughput of working with some of these industry companies that have the large machines can get you really affordable costs in order to actually sequence these isolates. So it's no longer hundreds of dollars to sequence an individual isolate. We can get it down pretty low. Now, we have an established laboratory and a process that, again, not every hospital is going to have, but this shows us that these prices are competitive and we should be considering implementing this because it's no longer very expensive. So what did we find? Again, I said we started in November 2021. We had to do a cutoff for the sake of a publication. So for the same 2-year time frame, we sequenced 4,700 isolates. You'll note that we had 172 clusters, 476 patients, which is larger than what we saw before. And our turnaround time is 15 days. So from the time that you take a bedside culture from the nurse to the time that we have genetic output of are they in an outbreak is 15 days, which is plenty fast for bacterial outbreaks. It's not necessarily fast enough for viral outbreaks because the time that you get that viral result back from genetic data, your index patient may no longer be contagious anymore. Whereas these bacterial outbreaks are really protracted. They last weeks, if not months at a time. That lets you have good interventions. And I do say we are still sequencing today. We are over 4 years, or almost at 4.5 years of real-time weekly sequencing and making these interventions. And you can see from the right, our figures, similar to our other ones, sequence a lot of Pseudomonas aeruginosa, a good amount of outbreaks there, same with VRE. But some of these outbreaks were really interesting. We've had issues with endoscopes at our hospitals where our endoscope-related outbreaks of single endoscopes would be 5, 10, even sometimes 20 plus patients, all septic from a single contaminated endoscope. Now, what happens is that we have 2 patients, genetically related isolates. We saw that they both had endoscopy with the exact same endoscope within a short time frame. We remove that endoscope. Sometimes we find that there were issues with that endoscope. We fix it, and if we can put it back in. But now all of our endoscope clusters stop at 2 patients, again, which is observational. But from our prior experience, these got very large. Other interesting outbreaks here as well is we had multiple clusters from outside facilities where patients would be sent to us. There's this one long-term care facility where they were a ventilator facility as well. Kept sending us patients that were septic with Proteus infections, uroseptic. And we let that facility know, hey, we do this program. All these patients have the same infection from your facility. They did an investigation and found that the single-use filters on all the ventilators were never being changed. So it allowed them to make infection prevention adjustments because of that type of data. We also published separately too as well, and the extreme drug resistant outbreak of contaminated eye drops. Our program actually found way before any public data was readily available. We had 2 patients with genetically related isolates, nothing in common, so we couldn't do anything. But then months went by and our CDC released all this data and this genomic data, and we were able to show that our patient isolates were in that outbreak of contaminated eye drops of XDR Pseudomonas. And we found actually that one of our patients had documented in the chart they had used the eye drops that were contaminated. So if all facilities across the nation were doing this, that outbreak hypothetically could have been detected much earlier. But every time that we detected an outbreak, we saw a transmission route, we made these interventions. So our infection prevention team did either education of staff, enhanced cleaning with our infection or our environmental services team, which we know from the CLEAN trial is really effective at stopping HAIs. Audits of hand hygiene audits, cleaning audits, whether we have to remove the endoscope, the device, or other ventilators that we would find. A lot of education went into this. But we showed with this graph on the right that the takeaway from this is that essentially 95% of the time when we made an intervention, the outbreak stopped on the intervention that we made, on the route that we made, compared to previously, these outbreaks used to get much bigger on the same route of transmission that was suspected. So we had good counterfactual data that showed that we were effective in stopping our outbreaks, which when we quantify it, we said over the course of 2 years, we prevented 62 infections, 5 deaths, and same as our modeling study, saved $700,000, which when we had to pitch and talk to executives, we have to put it plainly. There's a 3.2 ROI. So every $1 we spend, we save $3. And that's the way that we have to pitch it to executive leadership, because infection prevention, as we all know, is never necessarily a cost generating group. We are mainly a cost saving, but it can be very difficult to prove that. And here, in a very conservative model, we have shown we are very cost savings and we're very confident, and we also save lives and infections. And luckily, we work with a great media team that lets us tell this story publicly, because one of the feedback I get from colleagues is, isn't your hospital worried about publishing outbreaks or talking about outbreaks? And no, quite the opposite, is that they want to show off that we are the only hospital doing this and we are innovating this, and everyone else is trying to catch up to our hospital. So that's why we're able to publish this type of data. So looking at future directions and your own hospital. So others are doing the same. It's not just Pitt UPMC. On the top left, the Children's Hospital of Philadelphia in Pennsylvania did a large Staph aureus sequencing project in the NICU and found lots of transmission of Staph aureus that go undetected in the NICU, and now are shifting potentially into a real-time model where they're able to stop transmission. Denmark, with Susan Hostler's group on the bottom left, has a very similar program to just what we're doing, where they're sequencing almost all of their infections, and also showed cost savings just as we did. They could be saving 1.25 million and avoid lots of disability adjusted life years. And then Australia on the right, Patrick Harris's group, where they started doing multiple hospitals with routine sequencing of many of the high risk pathogens. So it's not just us, and others are also saying the same. A Nature review in the top left by Mary Hayden out of Chicago here in the US did a massive review about the current evidence for HAI prevention, showed that this is where it's going. And on the bottom right, a massive working group published in the Lancet with Sharon Peacock, James Price, and even a couple of our own CDC people who are here in the US show the exact same thing, that infection prevention is moving towards this genomics for prevention of infection. So a lot of people are saying this is where the field is moving. So we all say, the evidence looks great, the cost is coming down, but how do you actually get it into your hospital? And this is something that isn't solved, and it's not going to be solved in the next few months, but it's the questions that we need to ask ourselves, and you need to ask yourself, is what are you interested in implementing? What pathogens do you want to sequence? Is it fungi? Is it bacteria? Is it viruses? What isolates are you going to sequence? What we do at UPMC and Pitt is we do, you have to be in the hospital for more than 2 days, but do you need to do less than that? Are you going to do every patient isolates or are you just going to do the first time they have a Pseudomonas infection, or are you going to sequence all the other ones? How are you actually going to sequence it? Do you have in-house capability? Do you have academic capability? But more importantly, is that academic capability able to make a real-time turnaround time and intervention, or is there a commercial solution that's available that lets you do that? And then most importantly, like from a diagnostic stewardship perspective, do you actually have the capacity to make interventions? Because sequencing in itself is useless unless your infection prevention team can make interventions that are guided by that, because you're not going to stop transmission just by sequencing. You actually have to intervene on the transmission. So are your infection preventionists trained? Do they know how to interpret the data? Do they know what to do with the data? These are all questions that you have to ask yourself. The next step, what you have to do is you have to make the case for your funding, because right now, at least here in the US, this is not reimbursable. We can't charge this to anyone. Our program is 100% grant funded from the NIH. We do not have any in-house funding. So we are trying to make the case for funding. But what we suggest doing is go back to that prior slide, gather all that data that you want to sequence, and then use our models and other people's models to look at the potential impact that genomic surveillance can have on your facility and model the potential cost savings that you have. So this calculator I have on the right, like a true academic, we're working on another publication. We're trying to essentially make this calculator publicly available where you can input your data and look at your potential cost savings. But you can actually do this yourself by looking at our outputs in our paper, where you essentially say how many isolates that you want to sequence, the projected of how many of them are going to be genetically related. And through a systematic literature review that I've done previously, on average, it's about 24% of isolates that are sequenced will be genetically related in a genomic surveillance perspective. And then how many infections can you stop? And our model in both studies showed that you can reduce that transmission by 20%. So then you can assign a cost for those infections, and then you can calculate how much you would have spent versus how much you're going to save in the end. So in this hypothetical scenario I put in our calculator, you sequence 2,000 isolates. In the end, you can have net cost savings of US dollars of 1.4 million at that institution per year. Like I said, this is a manuscript under preparation. We hope to submit it soon, that makes this readily available for hospitals to actually utilize. But moving on, you can make that pitch internally, but what are some of the field's barriers to actually getting this to a realized routine tool in infection prevention? I had the fortunate to be able to talk to many people in this field, some in the UK, some in Australia, and here in the US, about where are we going and what are the barriers. And like true academics, we wrote a paper on it and highlighted some of them here, which we published now 2 years ago in January of 2024. But we tried to systematically say, what is the current state and where are we going? And we all agreed that the evidence, at least for bacteria in routine genomic perspective, is there. Lots of people have done studies that shows that these outbreaks go completely undetected. We could make interventions and we could stop them. But also on the opposite end, the one in the middle by Ariana Miles J, where they sequenced C. diff, found no transmission whatsoever, which told them it's actually a stewardship problem. It's not a transmission problem. So there are a lot of utility in bacterial outbreaks. I think the issues with fungus is that it's sometimes hard to analyze, and with viruses, we need more rapid turnaround. But viral genomic surveillance is still very useful to give us a historic view about, what did we do well, what did we do wrong, how much in-house transmission did we see versus community transmission. That's what James Price has been working on too with COVID-19 and some other respiratory viruses. That evidence is there. And that's kind of what I highlight here, that there are multiple studies out there that shows that we can find outbreaks that go completely unrecognized. There's differences in the types of pathogen, but we do need, again, more evidence, the better, more modeling outcomes and more evidence on cost savings and effectiveness about how to optimally use all of this. And then financial. Lots of studies out there, not only just ours, there are some other studies showing net cost savings. They're all pointing in the same direction. I haven't found one single study that has shown if you do genomic surveillance, you will actually lose money in the end. They're all net savings. But a lot of those centers were large academic medical facilities. We need more evidence about the impact on smaller hospitals, suburban hospitals, rural hospitals. How does that actually work? And what type of resources do you need in those facilities to make it cost effective? And then infrastructure, not everyone has the ability to have this in-house laboratory like we do. There has to be dedicated equipment in actual lab spaces, or there actually has to be some type of commercial solutions that allow hospitals to have access to that as well. And then analysis on the best types of practices to implement genomic surveillance programs. Methods, there is no one single agreed upon method, but just like any laboratory developed test, I don't think we need a consensus on one method. All we need to be able to agree on is that if I sequence my isolates and you sequence my isolates and we do our own analyses pipelines, will we come to the same conclusion on who's in the outbreak and who's not in the outbreak? In the end, that's what matters from an infection prevention standpoint. Can we all agree on who's in the outbreak, who's not on the outbreak? And that's where I think professional societies can give some inputs on this type of methodological outcome. And then some of my favorite topics is the legal, ethical, and regulatory guidelines, which are lacking essentially. There hasn't been one single professional society or institution that has any document, any suggestion, any endorsements, let alone on that, on any of the use of genomics for infection prevention. There's a lot of ethical considerations of data security and privacy of sharing whenever we're going across hospitals, equitable access. Do laboratories need to be certified to do this type of work? And what type of billing mechanisms can we do to actually make this something that we can implement into insurance practices or healthcare practices? And that's where I'm hoping that professional societies can really step in, because this is where they need to get ahead of, another institution just coming in and planting their flag and saying, this is how we're doing it. And that's what I'm hoping to see in the future. So what we do right now is on the left, where you have some hospitals like us in the bottom where we do this in-house surveillance. Some hospitals do no surveillance or sequencing whatsoever. Some hospitals do third-party commercial, or they use their public health group to get some data. But there's outbreaks that are missed both at the actual hospitals, but also across the facilities themselves. We could be catching cross-facility transmission or contaminated product transmission. How I think it's going to work out in the future is no one's going to have all internal genomic surveillance. It's going to be a combination of using our public health partners, our commercial solutions, our in-house sequencing, but we need to share the genomic data publicly, preferably with public health, because from a regulatory legal perspective, public health is going to be the only people that is going to allow to connect the dots between different facilities and do that type of analysis where they can notify about cross-facility outbreaks and then have internal facility outbreaks as well. It's going to be this combination ideal state where everyone's doing something different, but we're sharing all of that genomic data together. But how we get there, I'm not quite sure. Like another true academic too, I keep writing op-eds. I wrote the one on the left back in December 2024 in Stat News. Here in the US, we have something called PulseNet. I know there's a UK equivalent as well, which is the foodborne illness outbreak. Every time you see a foodborne recall, it's typically connected through PulseNet. And that's what we need for hospitals. We could have detected that contaminated eye drop outbreak, or these heater cooler device outbreaks, or all these other outbreaks that are spread out across the US much quicker if we had a PulseNet for hospitals. And on the right, I wrote another one for MedPage Today, talking about the endoscope outbreak, back in 2012, where it was just newly discovered, all these people got sick. We could have detected that much earlier and stopped it. And individual hospitals could be preventing these outbreaks that we know are going on undetected in their hospitals if we're able to adopt it. So what I've learned, though, is that, of course, not learned, I've always known this. No one reads paywalled, peer-reviewed academic papers and journals. So part of what the next steps are educating not only necessarily the public, but hospital and healthcare leadership, because a healthcare executive does not know what genomic sequencing is from a pathogen standpoint, let alone that this approach is available and effective and cost savings. There has to be some level of education that we as researchers and we as infection prevention have to do for our healthcare leadership to show that this is a new tool, it's an emerging tool, we should invest in it now. and get going. But I think the future state of genomics, as I outlined there, is that globally we'll have some type of healthcare genomic surveillance where we can detect healthcare outbreaks, but also importantly, community outbreaks. There's a lot of community outbreaks that you can detect through genomic surveillance. One of the military hospitals here in the US just did a good example of that, where they were sequencing their invasive group A strep, mainly for healthcare transmission, but they found a large community group A strep outbreak that they were able to tie back to, I believe it was like a type of wrestling group that was meeting, and they were able to stop the outbreak through there. So we were able to detect community outbreaks too, but we'll have some type of data sharing across facilities, across countries, where we can collaborate on these type of outbreaks, which will be very impactful for looking at AMR research about where we're going, how plasmids are transmitting, how AMR is spreading. All of this is going to be net beneficial to infection prevention, to AMR type research, and I'm hoping that we can get there one day. So our lab is made out of many different people. Lee Harrison is the head of our lab. He's been my mentor for over 10 years now. But a lot of people make this happen in our lab. But more importantly, not more importantly, very importantly too, is our infection prevention team, where they're actually doing the interventions every single week. I used to be a part of this as an IP on their team. Without them, none of this research and actual utility into actual practice is possible. But thank you for letting me present. Thanks, John and Phil, and looking forward to a good discussion, because every time I give something like this presentation, I learn more, and it makes me change about, how do we need to have these discussions to actually translate this into applied tools. So hoping that this was useful for you.
Alex, thank you so much. I really admire your passion for the subject area, and just a great sharing of all the resources that you've been developing. I think, one of my questions, and you kind of answered it really, is where do we go first? And I think that advice that you're giving to people about how they get started in genomics is really good. And developing those tools, those calculators, I think will be a really beneficial way that people can kind of delve into this a bit further. I wanted to start by talking about, how we get wider adoption of this. And you talked about the lack of support from maybe some of the bigger agencies and organizations. Are you doing any work to try and incorporate, those types of organizations, and where do you think the next steps are with that?
Yeah, I think so. As my disclosures, I just joined the board of SHEA as well, and obviously want to improve all of infection prevention practice together. But there is some interest from a professional society group of, like, we can say that this research is coming out, we can put it out there. But I think there could be some type of like multi-society collaboration where all we need is just, a white paper, a statement out there about this is available. I'm not even looking for an endorsement. I'm just saying, can we educate mainly that this research is coming up? It's a useful tool. Because I know oftentimes societies will do these guidelines, these endorsements and things like that. But that, that's not necessarily what we need right now. And I recognize a guideline takes, months of work and, the grade scaling and things like that. But I think the research is still coming in about what's effective, what's not effective. I talked about viruses and fungi. And by the time that a guideline is created, new research is already going to be out. I think it's going to be outdated. So I don't think we should be doing that right now. I think it should be more of a educational awareness that the societies can do relatively nimbly.
Good advice.
Okay.
John.
Yeah, thanks, Alex. I wonder whether there's some implementation journeys that could be followed with this idea. I'm thinking about things like moldy for bacteria, for microbial identification in the lab. At some point, that transitioned from new to embedded, or respiratory metagenomics, which is newer, but I think already along the path to implementation. Could the idea of proactive whole genome sequencing for surveillance follow another technology's path into routine practice? And if so, which one?
I mean, I think 100%. I think too that new technology can be scary, and I admit I was even scared. I remember we had our lab meetings where my mentor Lee Harrison was just like, "What are we waiting for? Let's just do it." And we all had these worries that, like, well, how are we going to do this? How are we going to get it this fast? It's gonna be difficult. I mean, these were all good questions, and I will say for the first like 3 months, it was clunky. We weren't quite sure what we were doing, but eventually now it's routine to us. It's quote easy. And I think, John, just like you said with MALDI, I remember my mother-in-law was a microbiology med tech for 35 years before she retired, and she would be like, MALDI is taking over. Like, what are like, how are we doing this? Like, we used to have to, do all the different tests and all the things to actually figure out what it is. And now, majority of hospitals, the larger hospitals are all using MALDI, and we are going to forget what it was like to actually have to do those different reactions and the different tests. So I think in a similar fashion, eventually we can embed this into clinical labs where all a med tech has to do is load a bacterial sample onto a machine, and then an infection prevention team gets notified of outbreaks. Because in the end, like we can't have med techs have to do all of this manual labor and this manual work. Med tech, there's already a med tech shortage, at least here in the US. And we have to have some type of automated solution where we don't have to have all this expertise in the end, I think.
Thanks, Alex. So we've got a couple of questions from the audience. Irene asks, do you know if it's cost effective if you've got mostly MDRO carriage, so colonization instead of infection? So is genomics still cost effective?
Yeah, so Susan Hessler's group and Denver looked into carriage specifically too. She was able to, and her group was able to find cost effectiveness even with carriage sequencing as well. And then, so I know that her data at least shows the cost effectiveness there. Carriage is very important, though. That's a great point. The Children's Hospital Affiliate Group looked at carriage. We published separately. I didn't put it on here. We did VRE carriage sequencing as well. Found massive amounts of transmission from carriage. So I think being able to sequence carriage will help us identify transmission better. And at least the one data point I'm aware out there shows that it's still cost effective in the end.
Just a follow-up, Don, if I can. Is that something you're actively looking at now in terms of colonization? And again, what are your parameters when you're looking at colonization? Is it when patients are in hospital for a certain amount of time, or can you maybe share some insight into that?
Yeah, so we obviously had a lot of VRE transmission. So we did this analysis where we, sequenced all of our VRE rectal swabs for about 9 months and found about 80% of them were matched to clinical isolates. And actually, Phil, you make a good point. In the end, we actually don't do sequencing of VRE colonizations because, if 80% of your isolates are transmitted in the hospital, your interventions are just going to always try to hand hygiene, cleaning, and things like that. We were already doing contact precautions. Obviously, they weren't working there. So sometimes when your transmission rates are so high, that's actually a case where sequencing might not be as helpful because everything's going to be genetically related.
Okay, so can I ask a kind of related question to the one about MDRO colonization versus infection? And I said we'd be critical at the start, so forgive me. I hope this is an academic forum. You presented a picture that every insight from whole genome sequence is actionable, but that's not always the case, is it? You sometimes get insights from genomic surveillance that just aren't actionable in a practical sense. You might get 3 bacterial isolates over the course of a year in different parts of the hospital that are linked genomically. They're transmitted, but you actually can't do anything about that. I wonder if you could comment on that.
Yeah, John, that's a great reviewer two comment. And I failed to leave it on there in our in our paper. We were only, of all of our isolates we sequenced, we only found what we called epidemiological links, meaning that evidence of potential transmission in 60% of our sequenced isolates. So 40% of the time where we sequenced, we had something that's genetically related, meaning potential transmission. I would review the chart and find nothing in common among the two, nothing at all. And from an IP standpoint, there's nothing that you can actually do with that. So I actually think, one of the struggles of implementation that we've adjusted since then is that I used to just send all of the outbreaks, whether or not I found evidence of transmission, to our IP team. And excuse me, our IPs became so busy that they were duplicating my review, that we actually no longer send to infection prevention a cluster that doesn't have a clear epidemiological link, because we don't want to waste their time in reviewing an outbreak where they're not going to do anything different in the end. So that's a great point that, it could be an issue with our thresholds of what we call genetically related. It could be an issue of, we're missing colonization, we're missing other patients that's connecting them to. And, John, that's a great point. There are a lot of limitations of genomics that have to be, I think, nuanced whenever we think about what interventions we're making.
Okay, but I like the idea of only disclosing the actionable insights. That's a smart way to go, because then you kind of retain almost credibility for the whole genome sequencing, because I think there's a lot of suspicion amongst frontline practitioners say, oh, well, the robot's got it wrong. So actually focusing on the actionable insights makes a lot of sense.
Right. Yeah, there was this a study out of one of the New York City hospitals where they looked at this tool called SAT scan. It's a geospatial temporal outbreak, and they tried to see, was it good for hospital outbreaks. And they found, I forget the exact statistic off my head, but it was something close as like 90% of the outbreaks that the robot detected were actually non-outbreaks. So from an implementation standpoint, the IPs are going to get so annoyed and so tired with that thing that they're not going to want to use it. And that's the same thing that we're trying to do here, is that we want the IPs every time we send them an outbreak to trust that it is a true outbreak and here's exactly where it's happening.
Thanks, Alex. The questions are flying in now, so please, guys, use the upvote if you'd like to get the question asked. This is one which I actually tempted myself to ask you, Alex, about bioinformatics. Saeed is saying that one of the challenges they have is a lack of bioinformatics expertise and could be quite limited. So do you have a dedicated bioinformatician? And, I guess maybe to expand on that, what's your advice about how you generate that expertise and how important is it for the whole genome sequencing, kind of pathway?
Yeah, so I will humble myself because I have imposter syndrome. I've actually never run command line to do a bioinformatic analysis myself. I don't know how to do it, nor do I think infection preventionists need to know how to do it in the end too. But yes, we do have an in-house bioinformatician, Marissa Pacey, who is wonderful and again has made available all of her pipelines that she's put up there. So the answer is, I don't think you need an in-house bioinformatician, because in the end, not everyone's going to have access to that type of academic availability. If you want to build your own in-house pipeline, as we showed in our available cost saving or our cost analyses where we have FTEs that are built into it, you can still be cost effective if you want to go for that in-house route. But I think that expertise relies solely on the bioinformatician. I will walk back my prior statement a little bit. I think there is some importance in knowing the interpretation of bioinformatics analyses. I can sound intelligent in those conversations. I might not know the nooks and crannies of some of the analyses. But just like where infection preventionists know, like a two-step process to do C. diff testing, what a positive result actually means, what goes into that. Similarly, from a genomic standpoint, what is genetically related? I think there's some utility to knowing what does it mean, but in the end, I don't think everyone needs to know bioinformatic analyses.
I think that should give everybody on the call some confidence that this is achievable, because I think the bioinformatics is the really scary part of it. Thanks, Alex. John.
Yeah, agree. So I'm going to try and pull a few questions together, really, that are along similar lines. So a question from Hester, another one from Catherine here, around the sort of the relationship and the interplay between the people who really understand the bioinformatics and the genome sequencing, and those that are at the front line who are actually doing the doing. So it sounds like your current role is not within the IP team, so you sit outside it in a more academic forum, but you're feeding information in a kind of filtered way to the IP team. Do you think that's the best model?
I think it's a great model for where we're at right now, because we're still understanding what works, what doesn't work. I mean, we've changed so much of our pipeline. We actually used to use, for my genomic people on the call, a 15 SNP threshold for most of our pathogens. We've actually reduced that down to 10 because we found out that most of them from 10 to 15 had no epi link, so there's non-actionable. We've changed our pipeline for C. diff analyses. We've changed our reporting. So I think as we're in this phase of we're figuring out what works from an implementation standpoint, this type of relationship is good. But I think whenever we think about expanding into different hospitals, more hospitals, let alone even our own system of hospitals here, I think that model needs to change to something that's more applied, less academic, more of like a moldy type solution where it makes it more readily accessible. It makes it really easy to understand. I mean, right now I'm just sending Excel spreadsheets to my infection prevention team. And in the end, I don't think that's what it needs to be for everybody. So I think we're still figuring that out, what that future model is going to look like.
Okay, and how much have your SNP cutoffs, your definitions of outbreaks been co-developed with frontline teams?
We get good feedback. So in that 2-year analysis, I didn't put it on here. We looked at the relationship between finding an epidemiological link and a pairwise SNP distance and found a significant difference. So their feedback of finding epidemiological links along with my review allowed us to change our pipeline into that interpretation. So I think there is good, as it should be, you need that feedback from your infection prevention team about what to change. And I think any type of commercial solution out there needs that change, because as we're using this technology, we're finding out what doesn't work well, and that's what we need to adapt to.
Thanks, Alex. Question here from Susie. Given your experience, do you routinely test endoscopes, or do you only test them if you suspect a problem?
Yeah, in the US, I'm not up to date on the FDA guidance anymore since I'm no longer on a frontline IP. But we still do like at least I think yearly culturing of every single endoscope. And then if there's a positive, we sequence it as well. But that's unique to us. But I think it's just a yearly check.
Thanks, Alex.
Okay, so look, you've just called me reviewer too, Alex. So I'm going to step into that role now, okay, and ask you another unfair question. But it's about the healthcare economics, and maybe from a resource constrained NHS setting where everybody's trying to save a bit of money. So let's say you made a case for this process, and the hospital board, whoever it was, says, we love that. Yes, you should absolutely invest in that. We can see tangible benefit, but you've got to cut back another aspect of your service to fund it. Would you do it, and what would you cut back on?
Oh, contact precautions? We already did that though.
No, we haven't done that. We haven't done that here.
Oh,
we're still full on contact precautions all the way, pretty much.
well, there we go. I would say contact precautions.
Okay.
I think that, it's hard to pick and choose, like, what do you need to cut back? The one thing I think you can say is, from a resource allocation standpoint, we know our IPs are chasing false outbreaks. And then this is a reallocation of FTE resources to true outbreaks where we know we can actually make an impact. So there is something to say about resource allocation. In terms of cutting back, I mean, that is a good question. I mean, you can say that you can incorporate a lot of FTE changes where, your routine rounds can also incorporate the feedback of what you're finding into genomic surveillance, so it can get incorporated into there. But John, that is a great question. I need to think about what my response to the reviewers would be. But I will say, I think in the future, there has to be a way for us to bill for this in the end, because that's where a lot of the financial burden can be alleviated. That right now we can't bill the insurance or bill the patient for this service. But if we can do that in the future from an insurance, I know we have a unique, horrible system here in the US from insurance. If we can do that in the future, that will make it much more accessible.
Okay, great. Thank you.
I think probably one more question, John. Let me just cycle through here. Maybe just touching a bit more on that relationship with IP, Alex, and just kind of, maybe paint us a picture about how that works. It seems it works really well in your organization about how you can interpret the data and then translate that into the IPC team. And you gave some really great examples about how they've detected those outbreaks and they've put the solutions in place. I think the one about the contrast was the one which really surprised me. But just talk to us a little bit more about that relationship between yourselves and your IP team.
Yeah, so I think that's why our research group worked well, because during my doctoral training, I did part-time. I was working as an infection preventionist in the department in which we were doing this. So I was kind of like the liaison from the research team to what the actual bedside IP people needed to have. It's very academic from a standpoint. It's very low tech right now. So what our on the back end, we're doing everything in the background. We always say, if you ask any bedside clinician about what our genomic surveillance program is, they have no idea what it is because they don't know what's going on, and that's a good thing. So we do all the collection ourselves. We do the laboratory stuff. We do the bioinformatics. It gets sent to me, which I know isn't feasible. But every week I review the new outbreaks manually. I review the patient's charts, determine where they were in the hospital, what procedures they had, what healthcare workers were seeing them. And then based upon, an IP's review, say, this could be this unit or this procedure could be a likely transmission route. All I simply do is combine a line list in an Excel file and say, this patient, this cluster, this outbreak, which we have identification numbers for. Here's my narrative note about what happened to this patient. And here's where I think they got it from this other patient. And I do that for every single patient in the outbreak. And then I have a running literal just Excel spreadsheet of every outbreak we've ever reviewed. I send it to our infection prevention department, and we've had lots of meetings about, what this is, what it means, where to go from it. Every Wednesday, or they have a person who assigns it out to an infection preventionist, so it's kind of like a round robin. So like it's your turn to review this one, and then every Wednesday they meet about, each outbreak. What do they plan to do? What have they done? And then they actually go out and do it. And then from our standpoint too, which is also really important from an IP standpoint, recording what interventions they did and when they did those interventions in an Excel spreadsheet. Again, it's all Excel. And then, because that's important from an academics perspective where we can look at outcomes, but also from an IP standpoint, is what they're doing effective and can they actually record that? And then any next steps. And so it's just two Excel spreadsheets, me sending patient line lists, them documenting what they're doing, when they're doing it. And that's all it is right now, is it's very low tech. And that's all you need to start. I will say there are technology things that we would love to add on. I've talked about machine learning AI to help review the chart review, and maybe dashboards to help put it all together to keep you more organized. But those are nice to haves. The fact that we're able to do this quite effectively shows that any hospital can do this.
You make it all sound so easy, Alex. But that's what years of experience, I guess, teaches you. Alex, on behalf of me and John, we'd just like to thank you again so much. Tremendous presentation as always, and lots of learning, I think, for everybody on the call. So thanks, Alex. I'm just going to wrap up with a couple of final slides if I can. But yeah, again, a big thank you to Alex. So as you all know, we've done these webinars in partnership with the HIS and the Infection Prevention Society. We'd like to talk about our next webinar. We're delighted to welcome Dr. Jester Martin on the 4th of March. We're going to be talking about water hygiene risks in hospitals, and you can scan the QR code there to register directly. There's also a special interest group, Spark, that the Healthcare Infection Society are running at the moment around wastewater and AMR. We're open to accepting people for applications for that as well. So just to trigger your interest there, and all the information is available on the HIS website. HIS have their annual conference. I was talking to Alex about this before we started the webinar. I attended last year. It's a great event held in London at the Royal College of Physicians in June. I think the early bird is open now up until the 9th of March. So please check that out. And also you can become a member of HIS as well. And I know there's lots of benefits from joining the society around reduced fee and access to the Journal of Hospital Infection as well. Finally, just a message about IPS. Lots of good events going on being run by the society. So you can find out here everything that's going on. There's some interesting webinars coming up, and I think we've got some events coming up around sustainability in March as well. So please check out the IPS website for all their events. Finally, and then we'll leave you in peace, you can see the live schedule of all our journal clubs and webinars on our website. And finally, we have all of our recordings online. So if you ever missed one or you want to catch up or you want to watch it back with a member of your team and do your own journal club, then you can do so on our journal club. YouTube channel. Okay, without further ado, bang on time again. Alex, thank you so much for your time, and wishing everybody a good day. Cheers, Alex.
Thank you.